Aditya. I'd now like to invite Dr. Vandana Nath, and she'll be sharing to us how we can, improve our outcomes of patients undergoing cataract surgery with pterygium, which is quite common in many parts of India.
Good afternoon, everyone. Thank you, Shell, for this opportunity in this stellar conference. All of us are bothered by pterygium, especially when you have a patient undergoing a cataract with the comorbidity of pterygium. How do I know whether it's going to impact? Now we are dealing with two things. We are dealing with a cataract and we are dealing with the pterygium. How do we know whether it's going to impact? Because any pterygium gives rise to some amount of astigmatism, some amount of aberrations. So what is going to be, how are we going to calculate the biometry, and what is going to be the choice of the IOL for giving a good refractive outcome to our patient? I cannot underestimate the value of the pre-operative evaluation, where you go like a resident and do the history, visual requirement of the patient, understand what is the patient's vision requirement, status of the fellow eye, and the most important is the counseling. So there are only three options. Either you do only the cataract surgery, leave the pterygium alone and operate it later if it progresses, operate the pterygium first and later the cataract, or combine the pterygium and the cataract surgery. So let's take option one, where we do only the cataract surgery, and these are our own cases. This is a 76-year-old lady whose left eye we had done a flax with a toric IOL, and now we are undergoing the right eye. Now she's undergoing the right eye surgery. This is a juicy grade 3 nuclear sclerosis, which we are ready to pounce on. But she knows that she has a long-standing pterygium, and patient is okay. It has never bothered her. So ideally, when we do the keratometry, we should have at least two different keratometry readings. You can use your optical biometers, and you can use for regularity of the astigmatism, you can use topography or a Scheimpflug imaging. Excuse me. And look for the regularity. For regularity must have this bow tie kind of a pattern that you see in the topography. Now this is thank you. These are the keratometry readings where you can see there's a minimum astigmatism between the steep and the flat axis. But even the small pterygium is not giving a very regular astigmatism. If you see this pattern, and this is actually the aberrometry profile, which I'm showing you now, and you see not only there is a minimum astigmatism, but that circle shows coma and trefoil. These are the higher order aberrations on the cornea, which even this small pterygium can cause. Okay? These are the things that cause the dysphotopsia and unhappy patients. And it has been known in literature that pterygium and its size have significant influence on the higher order aberrations of the eye. So we selected the IOL based on this patient's profile, based on this patient's eye, and we were not compelled to put a toric IOL in this because she has a minimum astigmatism, and we did a simple monofocal IOL with a 6/9 corrected with a minimum of residual astigmatism, which she was okay with. This is a case too which was very challenging to us. Absolutely doesn't want a pterygium surgery. He's a very active businessman. This is the maximum pupillary dilatation of this patient, and therefore he has been able to function with this kind of a pterygium. To make matters worse, he is nearly one-eyed. The right eye, if you can see, he has a multifocal IOL with an iris atrophy and a full thickness macular hole on the OCT, which we always do even with the fellow eye, even if it has been operated elsewhere. So coming back to the left eye, she has a very high astigmatism of you can see this K1, K2 readings, nearly 5 diopter of astigmatism. So what is the best we can do? Now, if you notice the dotted black line, we wanted to tell ourselves that now this is a sort of astigmatism which is showing a reasonable bow tie appearance. So can we reduce this person's astigmatism at least to give him a little better outcome? So yes, we did plan a toric IOL, and we used the Barrett's toric calculator. And we implanted a T9, and he is very happy 6/6 vision with a minimal residual astigmatism of 0.75 diopters. So this was the best refractive outcome that we could give him in spite of this long-standing huge pterygium that he had with a very high astigmatism. Now this is the second option. where we do a stage surgery. Which are the conditions where we do the staged surgery, where we do the pterygium first? This is a 57-year-old female with a fleshy pterygium and very high astigmatism, again of nearly 6 to 7 diopters. So we advised her to remove the pterygium first. And this is the surgery with a conjunctival autograft, which we always do with tissue glue. And we lowered the astigmatism and then planned a toric IOL with a regular astigmatism, and patient was counseled and given lubricants, 6-9 unhappy. This is just the surgical procedure. You can do whatever method you are comfortable with, and this is how we just peel it off and do a measured. This is the way and I've learned this surgery from watching Dr. Fogla's video. Dr. Fogla is here with us for the next talk, using tissue glue. And the next case is self-explanatory. This was a lady who had a huge recurrent pterygium. And yes, I did call up Dr. Fogla to find out what should we do with this patient. So he said, obviously, you need to take out the pterygium first. And this is the first week post-op, where you can see the large conjunctival autograft. And he had warned me that you will have a lot of scarring. So please warn this patient. And yes, we did warn this patient that she did have. But she was ecstatic because from CF 1 meter, her vision improved to 6/18. So we advised her to wait for 6 months at least for the corneal topography to stabilize and then put a spherical IOL, a non-aspheric IOL. And she was very happy with her 6/9 vision. So post-operatively, these are the patients where you want to keep a close watch, repeat the keratometry, wait for the keratometry readings to stabilize. And this was the case where we wanted to wait ideally for 6 months. And pterygium excision can significantly reduce most of the higher order aberrations, and topographic changes take time. So for any case where you have done a pterygium, at least wait for 6 to 8 weeks before you operate. If they are small and do not impact the keratometry readings, they can be left alone. If they are large enough to adversely affect, remove the pterygium first and then plan. The option 3, I'm not going to advocate from this platform because I'm going to show you examples of what can happen if you combine the cataract and pterygium surgery. This is a lady who was sent by the optometrist because she has never been comfortable with glasses. So the optometrist told her that, no, I can't do anything. You please get your cataract done. And you can see that there's hardly any cataract. And I'll show you, it's a double-headed. This is the aberrometry profile. And if you see this corneal profile here, all the aberrations that are coming from the cornea. The high astigmatism and the higher order aberrations. The internal, which is the cataract, is hardly any aberrations. And this is the quality of her vision. So which is the deterioration of the quality is because of the cornea only. So we had explained to her and we made her undergo, this is the high astigmatism, 5 diopters. So this is before we did the pterygium surgery. This is what we are getting, the toric T8, okay? And this is post-op, day 1. This is 2 weeks post-op, and we waited. This is after 2 weeks, all the aberrations on the cornea are gone. Her vision quality has improved. So we wait for 3 months and then do the surgery. And this is what I'm showing you, that if you had combined this pterygium with the cataract, what IOL you would have implanted. Even if you are going for a monofocal, you would have done a 24 diopter. So with the change in keratometry, not only did the spherical diopter change from a 24 diopter to the 22, but look at the toricity from T8 to T2. So you've had a very bizarre refractive outcome if you had combined this surgery. This is the last case, 65-year-old female. She's having this pterygia double-headed pterygia since 1 year. So it is a recent onset only. And if you notice, this is a thin, a thin pterygium with vascularity with this growing edge that you see. And a good grade 3 cataract as well. So again, these are all the aberrations, including the cataract related and the corneal. This is the poor quality of her vision. And this is the surgery that we performed. This is another trick I learned from Dr. Fogla, is to reverse the beveled blade, the 15-gauge blade, to reverse it and peel it off. Because I know this cornea was not very scarred, and this pterygium would not have been very adherent to the cornea. So I reversed the blade and just peeled it off. This is post-op day 1. All the aberrations are gone. And this is the quality of her vision with just the pterygium removal. This is post-op day 10. And this is now her biometry that we got with a T3. And this is what we implanted. And 1 month post-op, she is 6/6. And we waited for 5 months after the pterygium to do this. So the insights are ocular wavefront aberrations constitute the quality of vision. And topography is a must. We advocate a pterygium surgery first if it's impacting the K readings. And we do not advocate combined surgery. Thank you so much.
Thank you, Dr. Vandana, for that excellent array of cases. And I think the most important take-home message is counseling, because both the patient as well as the surgeon are in a hurry to operate the cataract. We are in a hurry, particularly if it's summer season, you don't have any list for next 2 days and the patient is willing for cataract. Hold the brake and follow all the principles that Dr. Vandana has shown. So, and the second is that the patient quite often is not very much aware about his pterygium. He's just come prepared that, no, I just want cataract surgery, forget pterygium, this I have since many, many years. And however benign he may look right now, post-operatively, if he doesn't see well, he's not going to accept whatever excuses or whatever explanations that we are going to give them post-operatively. So I think the aberrometry profile as well as the topography is not only useful for us scientifically to document, but also to explain to the patient that not all of his problems are due to his cataract, but most of his problems are due to the pterygium or the irregularity that is occurring due to the pterygium. And not all of his problems will be solved just by either alone pterygium surgery or pterygium followed by cataract. So lowering down the expectations of such patients is also extremely important. But I'd also like to value Dr. Fogla sir's comments on how you would, sir, approach patients with pterygium and moderate cataracts, which can also wait for a while.
Well, if you're looking at premium lenses and you want to give your patient the best refractive outcome, I think a stage surgery is the best approach. And with the current patient's expectations that we have, every patient wants to have good visual acuity after the surgery. It makes sense to remove the pterygium. So cosmetically, it looks great, and you can get better IOL power calculation, and you can give your patient better outcomes.
Thank you. Yeah, please, ma'am. Please.
Post-pterygium surgery, yeah, at least 6 to 8 weeks. But if it is large and across the pupil area, please wait for at least 6 months, as I showed you. Yeah.